Okay. So I think we're on in the comments. Folks, tell us if you can hear us and how it's looking. Can you guys hear okay? One person said louder. Just make sure that that's all right, you guys. Chime in if it needs to be turned up. Sounds good. Okay. You're going to make everybody dizzy, Craig.
I'm sorry. I'm trying to make it so you're not looking up my nose.
Oh my God. Okay, I'm going to keep talking so you guys don't have to look at that because when I talk, it takes his video off the air. But sorry about that. All right, there you go. Perfect. That's a great picture. That's a great picture.
Nice picture, huh?
Yeah.
That's when I was
Okay.
younger and I had mustache and hair that wasn't all white.
Perfect. Thank you, Randy. They were a Christmas present. Mark, so you can see the scroll at the bottom. All right. Very good.
There we are. Hi, everybody.
Perfect. Okay, and I think I got the delay turned down a little bit, so it doesn't seem like we're that far behind. Maybe like 15 seconds instead of 30. So hopefully that's good. Handoga says that was your mugshot, Craig.
I doubt, yeah.
Okay, let's see how many we got here. Looks like we're up to 73 watching, so we'll just give it another minute or two here. And people are still logging on, it looks like. And then in a second, we will get started. Yeah, it's a terrible look, Chief. Sorry.
You sound better, though. You don't sound like you're in your bathroom.
Well, that's good. Thanks very much, Chief. I appreciate that. While you're admiring that, Chief, maybe just make sure that the scroll going across the bottom of the page says the right things. That I didn't type anything wrong. Billy, I am not a gamer. I promise you, not even a little. Okay, so we got about 75. It looks like. Thank you, Chief. All right, so looks like we're doing good there. So what I'd like to do is just go ahead and start by giving everybody a general situational update as to where we're at with this whole thing. And I will try to share my screen here and see if I can make that work. We got lots of bits of technology going on here. Let's see. Okay, a couple of people said I need to be louder, so how's that, you guys? Okay, great. Can you guys see this map that I put up here with the Florida cases? Hopefully you can. And we'll just go through the quick numbers where we're at right now. 6,338 cases. Uh-oh, can't see it. Let's see.
I can see it on mine, which is interesting.
Yeah.
But I
okay.
can't see it on the stream.
Interesting. Okay, well, we'll skip that. But basically, we're at 6,338 cases right now with 772 hospital admissions and 77 deaths. That's for the state of Florida. We have continuing to have men outnumber women, and I'm hearing that as well on the um, severe and hospitalized cases, that's the case as well. So not quite sure why that is, but that is certainly happening. We have 5 deaths in Pinellas County and 45 hospitalizations in Pinellas County. Um, so I will absolutely put the link to the map, but basically just Google Florida COVID-19 dashboard. It's the DOH website. It looks just like the Johns Hopkins one that you might have seen. Statewide, we are, as I mentioned, at 6,338 with 77 deaths. If you look at the United States, we're almost 180,000 with almost 3,500 deaths. Chief Magnus, I believe that's all hospitalizations, but I'll double check with the health department whether that means they're currently in the hospital. I wanted to share a few things from you that I heard from my co-fellow from when I did my EMS fellowship. She is currently working as an ER doc in Brooklyn and also is still an EMS doc with the fire department up there. And I asked her last night, I said, how's it looking up there? We're still eerily slow here. And she said, ugh, so bad. She says she intubated 12 patients in 12 hours yesterday in her ER, and then went to do what they call telemetry, which is an online medical control shift up there. She said, today I had a patient with bilateral PEs and COVID, another one with kidney stones and COVID. There are no longer any patients without COVID. Yesterday they had a jumper suicide attempt, and he had COVID. The gunshot wound also had COVID. You get the idea. They've been running 6,000 plus calls a day for the last week. In New York, normally it would be like 4,000. They had 2 days that were over 7,000. So that's 50% plus more call volume. And so that's the concern for all of us, whether we're in the calm before the storm. She talked a lot about what they're doing in terms of sick call rates. She said they're seeing 25% sick call. And she also talked about alterations in the standard of care, including termination or resuscitation type efforts. So some pretty grim experience going on up there. And if you look at the curve of new cases by day, we are still seem to be on the upward trajectory. It looks like yesterday there was 875 cases reported, new cases reported in the state of Florida, and that was on a Sunday. On Saturday, there were 897. So it does seem to be still growing pretty darn fast. It's a little bit troublesome. We don't really know where we are, and frankly, the epidemiologic curve lags behind what's happening in terms of the people being infected by at least 2 weeks. And because of the natural history of the disease, how it actually looks, it basically, you always have delayed and less data than you think. So for us to know what's really going on, it's going to take a little while for us to figure that out. And unfortunately, I think some of us are thinking that our rate of ICU admission and or ventilator utilization will end up being probably the best marker of where we are on this curve, because it just the curve is just so delayed. When you can take up to 14 days to get symptoms at all, and when you can get up to when you can be sick for 2 weeks before you end up on a ventilator, it just delays the numbers by a long time. So it's very tough to see what's going on exactly. But I think surely we think that surely we think that the worst is yet to come, and we're sort of in the calm before the storm. The impact of the social distancing and all that stuff remains to be seen, what that's going to look like and whether that flattens out our curve or not. But either way, I think we all know we're probably in for a pretty rough ride for the next few weeks. I did want to mention that a lot of our hospitals are participating in planning with us, and they are working on their surge procedures just as we are. We are continuing to work very closely with them about how this is all going to work. Um, Craig, do you want to just walk through real quick the hospital interactions that you had put out recently?
Sure. You should have out in Target Solutions the EMS hospital plan. And basically, what we're trying to do is to reduce the cross contamination and exposure, and also to streamline our processes now before we get busy. And so, all of the hospitals agreed to that. It took a little while to get that through, but at this point now, we've got a solid hospital plan that for all patients coming in 911, we're going to be at the ambulance bay or ramp or the vestibule entryway for all patients except for behavioral health, cardiac arrest, STEMI stroke trauma. Those will transfer into the nearest treatment room as designated by staff. So Doc will talk more about clinical, but discontinuing nebulizers and covering a patient's head and chest with a hospital sheet to minimize spread of droplets for anybody on CPAP as we're going in. Most of the patients then will physically transfer outside, and then we do want you to move, right away to decon. And once you're decon and clean, then you can go back into the hospital, finish your report, wash your hands, use the restroom, go to the cafeteria. We just ask that you follow any hospital restrictions or screening procedures with courtesy. We're in their house, so we just want to be good about that. For non-emergency patients coming out, dispatch will call the floor when we're 15 minutes out or so, and then the hospital staff will bring the patient downstairs on the hospital discharge. For direct admits, we will bring them direct admit to the room, and let's see, the other direct admits with isolation precautions we'll also do at the ramp to minimize us being in PPE going throughout the hospitals. So initially, that was one of the concerns of hospitals is us being in PPE after we drop the patient, and we know that we're not going to doff our PPE until we've deconned our unit. So special transport teams, they'll follow all the guidelines, but transfer directly to or from the unit that the patient is coming from or going to. And so pretty good buy-in from them, and it should ease things for us. Doc?
Great, thank you. The other thing I wanted to ask you to just generally talk about is the overall strategy when it comes to incident command for this.
Okay, so we are running under an incident command, a unified command model. And before we're done, we'll have lots of different people involved in this, but the current group is a fire chief, an EMS chief, a Sunstar chief director, an EMS and fire administration representative, and a medical director representative. So at this point, it's MD1, Pinellas Park 100, Chief Slatterer, Site Pete 500, Chief Womack, Sunstar 200, Richard Sham, and County 500, that's me. And so we are meeting regularly to try to push forward. When we're done, we want about 7 1 to 2 page at the most plans that will handle dispatch, response, on scene, hospital transfer, decon, and just, we know as we get busier, we're not going to keep changing the rules. We're going to keep this simple and as tight as we can. And so that's been our approach to dealing with that. And then unified command, we can deal with working with Department of Health, working with ACA for facilities, those sorts of issues. Go ahead, Don.
Great, thank you. So, there are certainly a lot of moving pieces in this, and probably the piece that unfortunately is maybe moving the fastest is the clinical recommendations. Everything that we had thought we knew about what was the best way to treat this is now coming into question. Some people are beginning to think that the mortality rate they're seeing in Italy is a direct reflection of the fact that they were intubating people aggressively and early, and perhaps that's not the right thing to do now. So we are putting together a full set of COVID-19 clinical alterations, and they will be out in the next couple of days. I hope to actually walk through them with you on Thursday for our next live stream. So spread the word that that would be a really good one to attend. We're going to try very hard to have those ready and walk through them on the Thursday live stream. And I think that'll answer a lot of the questions that are out there. The unfortunate piece is really that we don't know a ton about this disease, and we don't know the best ways to treat it necessarily. So we are having to adapt as our understanding it adapts and improves, and we are learning more about it, unfortunately, the more patients that we see with it. So as much as we're going to try to get you a very complete and hopefully stable set of treatment recommendations by the end of this week, I think there's no doubt that there will be some changes of those that need to be made on the fly as we go through this. So that'll be a document that breaks down general approach and general things to consider with COVID-19 patients. But it will also be a document that breaks down what alterations in standard of care will do, but depending on what condition we're on. As you can see here, no, other way, there you go. Oh, this is hard on the thing. Up there you go. So as you can see up in the corner there, we are currently on condition yellow, and I even heard that there was some confusion about what condition we're on right now. So condition yellow means we are having some impacts, but we're still able to essentially maintain the standard of care. So there have been no real alterations to the standard of care at this point because right now, frankly, call volumes are down, hospital census is down, and we have the resources right now. We're doing maybe a few things to try and protect people as much as possible, largely related around screening callers, having the standoff assessment before you get up close and personal with somebody, making sure that you have PPE on, minimum mask and eye protection on every patient, and those types of things to try and keep us safe. But these regular standards of care do continue to apply, and no significant alterations beyond some protective measures have been put in play yet. And I think that's appropriate, and we'll strive to maintain that as long as we can. At the point that we get to really having our resources stretched and beginning to feel the weight of the increased patient load and the full hospitals, we'll get to a condition red. And at that point, there'll be definitely a little bit more alteration in the standard of care, because at that point, we're trying to really do the best we can with the resources we have available. And then hopefully we never get to condition black, where we're really overwhelmed and we are literally just doing the best we can to mitigate the disaster. So that will be the progression. I do think there's a strong possibility we'll get to condition red. I hope very strongly that we don't get to condition black, but that certainly is a possibility. So that's the overall picture from a clinical standpoint. I know we talked a little bit before about minimizing aerosol generating procedures and considering not using CPAPs and NEBs and maybe altering our approach to airway management. And I know there's a lot of discussion about that going on out there. I know that there's been a lot of different stuff on various social media and on various sources that you might look at for up-to-date medical guidance from what the ICU community or whoever else is talking about. And we will be getting you a clarification just here in the next day or two. I thought, frankly, we were going to have it ready for today, but a bunch of new stuff came out last night, and so no sense in publishing something that's about to be updated anyway. So I'll try to answer as many of your questions as I can today about that, and then I will try to have a really comprehensive and very clear document for you by the next time we get together on Thursday. Um, so with that, let's go into the Q&A session, I think. And yeah, the 1.3 acres site is really kind of cool. It has some good epidemiologic graphs that give you some idea of what we're actually looking at. So Jeff Roberts says, are we throwing out N95s after any patient contact or only suspected COVID patients? So Craig, you want to take that one?
Sure. So after you've had patient contact, you are to get rid of your N95 at this point. And so I will kind of give some other updates that we are working on alternate PPE. One of which that's very promising is to go to a full face respirator. Chief Tedesco and David Hudak designed this, and probably going to patent it and charge us a lot of money for it. But being able to put a HEPA filter, or we'd call it a fish filter from a ventilator, to sustain PPE. So we're buying as many P100 cartridges as we can, and we're building out this other capability, because now we're seeing you can't get N95s in the marketplace, and the KN95s that are coming in from China, we can't make a seal to make a mask fit that will seal properly.
Yeah, so I think the answer to the question is no. Once you've had patient contact, that mask is toasted. We're not doing the double masking or the reuse for more than one patient yet. Now, that could be something we get to, but we're not trying to do that right now. Obviously, if you were part of the standoff group and you never actually made patient contact, or you weren't within 6 feet of a patient or in an area where you think your mask would potentially have been contaminated, then that mask could be reused. And when you use that mask, we want you to document N95 reuse in the EPCR. The reason there are those two different places or ways to document in the EPCR is we really need to know how many new masks we're going through on a daily basis. So when you open and use a new mask, we would like you to document N95 new. And if you use a mask that maybe you previously had open, but you didn't have any real patient contact, and you put it back on for the next call, then that would be N95 used. And so that
is going well, by the way.
Which is, yeah, and you guys are doing a great job of that, and we really appreciate it, because that's how we're going to preserve our PPE and make it last for as long as possible while still maintaining a baseline protection on every patient. And to be perfectly honest, the reason we need to do the baseline protection is that up to 20% of COVID-19 infected people are asymptomatic, and we have had several instances where we had no inkling that this was a COVID-related patient, and it turned out later that they were positive. So that's why the minimum protection with every patient. That's why the step it up on any suspected COVID patient, any airway management, any cardiac arrest. We want you guys in the full ensemble because there's lots of aerosol generating procedures and lots of potential exposure there. And I'd rather use that PPE and keep you safe right now than take a chance with somebody who we didn't have an inkling, and then you're out for 14 days and maybe even get sick. So that's what we want to accomplish with that. So hopefully that clears up the issue about how to use the PPE, when to use the PPE, when to reuse, and how to document that.
So just run back through the baseline on all calls is?
Yep. So N95 and eye protection, whether that's goggles or face mask, on every patient. If you're up close and personal with a patient, you need to be wearing those. It doesn't matter whether it's a COVID patient or not. Every patient, we want you wearing those. If you have any suspicion that it's COVID, based upon the dispatch, based upon your standoff assessment, questioning and examining of the patient, based upon their symptoms, based upon any of that stuff, if you think it's possibly a COVID patient, then go ahead and step it up to the full PPE ensemble. So that includes the head cover, the gown, the gloves, and the shoe covers. And similarly, if you're going to be doing any kind of airway management or any cardiac arrest, we want you to do that full PPE ensemble as well. So this is what we think is the best posture right now to maximize the length of our PPE supply and to maximize your safety. So we're trying to find the right balance there so that we don't run out, but that we also keep you guys safe just as much as possible. Okay, so the next one is there's confusion about COVID-19 symptoms and sepsis alert symptoms being the same as far as fever, respiratory. What are we doing with the sepsis alert protocol? So there will be a section addressing changes. It's not actually a change to the sepsis alert protocol, but some minor adjustments to the treatment algorithms based on what we know about what's best for COVID-19 patients, and that will be in the document that comes out later this week. What we've found out is, or what's being reported is that aggressive fluid resuscitation is potentially problematic for these patients. So essentially we'll be giving you a little bit less fluid and encouraging you to go sooner to pressors if they're needed, rather than finish out a full couple rounds of fluid bolus. Next one is there any plans to have these new rapid tests available to us as used in South Florida to keep our families safe at home? So the concept of testing responders is a little bit complicated. So I know that there are rapid tests coming. As far as I can tell from what I'm hearing, it's still going to be at least another week and a half, 2 weeks before they make it on the ground where they could be usable. And I know people are working on getting them, and that's great. But we don't have them yet. So in the current situation, it takes generally about 48 hours to get a test back. It could be as little as a few hours. It could be as long as several days. And so testing an asymptomatic person is not particularly valuable right now. So if the question is, should we all be tested at the end of every shift to see if we've been exposed, the answer is, well, that wouldn't really do anything, because if you're asymptomatic, the chances are it's going to be negative. It's going to take days and days from your exposure for you to actually turn positive on the test. So that's a bit challenging. So the best thing I would say, if you have any kind of symptoms, then that would absolutely warrant testing, and certainly warrant staying home as well, and just necessarily particularly productive at this point. So let's see. Next is there's a lot of confusion about suspected COVID ISO precautions with treatment regimens. Some are under the impression they're withholding treatments, blah, 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 blah. Okay, good. Kenny, thank you for asking this. I actually did get a call from a hospital ED medical director today saying, hey, your guys got tunnel vision on the COVID thing and missed a STEMI. So this is really important. Just because you're in respiratory isolation precautions, we are not in a disaster mode right now. We're in a protection mode. And we need to do all of our normal due diligence, assessment, all that kind of stuff for these patients, just the same way that we would do in the emergency room. So please make sure you're not getting complete tunnel vision on the COVID-19 situation and missing the other things that may be going on with these patients. So the answer is, unless you've seen something in writing altering what the treatment protocols are, they are not altered. And we will give you a clear set of guidance on what those alterations will be just here in the next day or two. Greg says, is there any data on patient recovery after being placed on a vent? So I've heard 50% mortality. It sounds like
Wow.
Chief says 70 to 80%. Okay, sorry. Looks like we had a troll. So it's high. It's high, and there's a lot of discussion right now about whether keeping people off ventilators for as long as possible would actually be more beneficial if they actually deteriorate once they go on the ventilator. You've heard many people talking about how we're going to have a shortage of ventilators, but it may turn out that those images you saw out of Italy with the row after row of people on CPAPs, they had helmet ones over there, which I wish we had because they keep the aerosol in, but we don't. So there's rows and rows of people in those pictures from over there that are on CPAP and BiPAP, and that is actually potentially going to be beneficial. So our initial calculation about minimizing CPAP and going right to early intubation is turning out to perhaps not be correct. Um, but again, this is evolving on a daily basis, so it's pretty tough to give you a hard and fast answer on that. Um, we will try to make it as clear as possible in the guidance that we put out shortly. But yeah, the mortality rate is high. Um, if you end up on a ventilator, it's surprisingly high and troublingly high. Okay, next is I understand that GI symptoms are now part of the screening, but it appears that the CDC and DOH, however, still only list fever, cough, shortness of breath on their websites. Yeah. So the reason we've added the GI is that uh, somewhere in the neighborhood of up to 5 to 10% of patients, and I've heard this directly from ER docs that are seeing these patients, are presenting with a GI complaint as their primary complaint. Mostly abdominal cramping or diarrhea. And that is the reason that we added that to our protocol out of an abundance of caution to try to trigger the PPE and safety mechanisms on those patients. I understand that it's not on the CDC or the DOH, but we do think it was appropriate based upon the data we had to add those. All right, next is projections are looking much worse over the next few months. One ER intubated 8 patients today. If hospitals lose nursing resources, would county EMTs or medics be placed outside of hospitals? Maybe clarify your question. Do you mean in like alternate care places, or do you mean at the front door of the hospital to triage and sort? I don't think that we have any intention right now of assigning people to individual hospitals. I think we're going to have plenty of work to do on our own. But certainly this is an all hands community kind of an effort. And depending on how things are going, I'm not sure that anything is necessarily off the table in terms of adapting to treatment locations, treatment strategies. There was a big thing put out yesterday by CMS that all sorts of rules about who can do what are being relaxed. I just want to clarify that currently there's been no change here in Pinellas County about who can do what or who's credentialed to do what or what's within a scope of practice. Nothing, because our call volumes are still low, because our hospitals are still doing very well, there's nothing significant like that that's changed at this point for us in Pinellas. But the mechanisms are in place to allow that should we need to flex into it. But there are no plans to assign you to hospitals or anything like that at this point.
Hey, Doc, let me hop in on that one.
Please.
So there are 3 DMATs assigned to the state that are on standby to go to a hot zone. So we know that if we have an epicenter hospital, that would be a first strategy. That you saw during hurricanes is put a DMAT in front of a hospital to try to get the flow of people coming in and out, more orderly. And that's kind of why we wanted to start with the tents and the DMARC going into the hospital, so that could be expanded or contracted as need be. We are doing some side tasks, like we have 5 BLS Sunstar units that are out doing screening at nursing homes. And so you may see some tasks that we pick up if we think that we can accomplish it well. I think you could see retirees possibly coming back with a short credential cycle to just get them back up to speed. That could be something we look at.
Yep. I think there's a lot of possibilities on the table. Okay, so next thing was where do I find the information on the condition colors? Is it in the MOMS? No, it's in the Pinellas County pandemic plan, which your chiefs or leadership probably have. But basically, I can break it down for you that every day or like flu season is green. When things get to be how they are now, we're kind of in yellow. When we really get stressed, we move into red. And when we get into kind of a disaster mode, we move into black. But the plan is actually sort of the playbook by which the unified command structure is working through all of these issues. Craig, do you want to talk about that plan and who it is and where it lives?
Yeah. Sure. So it's kind of ripped up right now that we're taking all of these protocols and building them out, and we'll attach it all back together. But I will give you what I think is going to be our overall strategy as we go into the advancement. So let me just, it's a little bit lengthy, but I think it's worth kind of relaying, and then we'll get everybody's ideas. Pinellas County, all fire rescue agencies, medical director, Sunstar, are unified and maintain the safety of our personnel and continue to serve the community and patients throughout the COVID pandemic. As COVID pandemic escalates, the fire and EMS response model and other operational changes will likely be necessary to ensure the current level of service is maintained as service demand increases and the workforce is impacted with illness or isolation precautions. This may include 911 emergency medical dispatch protocols, alternate 911 emergency medical dispatch protocols, including we have them looking at the Card 36 pandemic card, alternate treatment standards, as Doc was just talking about, and potentially stay-at-home program for low-severity patients following Department of Health guidelines, or transporting patients to alternate destinations than hospitals. Such measures may be implemented to shunt low-severity patients away from hospitals to protect the hospitals from being overwhelmed for as long as possible, and to maximize the availability of hospitals to care for the critically ill. The field response may include 3-person ambulances and rescue units being operated as special rescue COVID units that respond solely to possible COVID-19 patients. Fire department rescue units and ambulances may operate countywide and interchangeably during the emergency to send a single resource for patient transport. For lower severity calls, ALS first responder units may not respond to preserve fire rescue capability to respond to fires, life-threatening emergencies, and other large-scale incidents. So think about as this goes through, if we have people out sick and a high demand for EMS, and then we've stripped our system, and then there's a plane crash or a fire. We had a 2-alarm, didn't amount to much, but at North Pinellas overnight last night. So we've got to keep our forward stance on that. A fire and EMS, further fire rescue agencies and Sunstar may need to have mixed crews that work for different agencies to field a fire engine, ladder, rescue, or ambulance, depending on system demand and the status of the workforce. COVID Unified Command has been established and will be maintained throughout the event. Unified Command, County EMS and Fire, EMS Medical Director, Fire Chief, EMS Chief, Sunstar Director of Operations. County, the fire chiefs, EMS medical director, Sunstar, not agreeing to fundamental changes in the system design change or the permanent implementation of priority dispatch or growth management. So in similar fashion, fire and EMS system has implemented alternate response plans and staffing models to effect evacuation and recovery after Hurricane Irma. We would be in a position to do something similar for COVID-19. The core emergency response plans will be reviewed by EMS and fire admin, the fire chiefs, the medical director, and Sunstar. Subsequently, all of these plans that we're working on this week would be reviewed and approved by the Medical Control Board and the EMS Advisory Council. And then enacting a Condition Red or Condition Black pandemic plan would be at the Executive Policy Group before implementation. So we'd be making, and Dr. Jameson sits on that, representing us with Dr. Cho, the sheriff, the county administrator, the county attorney, and the superintendent of schools. So just give you kind of a sense. So all of what I said is in planning. It's not here yet, but that would be kind of our game plan on a go forward basis. I'm still working with each agency to make sure that they can support that approach. And then that would go back to municipalities, fire districts, the ambulance company, up the chain of command, and the county government as well. So, Doc.
Great, thank you. Okay, so that's kind of the overall strategy that we're employing when it comes to this. Next, a couple of people have said the goggles are fogging up super fast and make it impossible to see.
We'll try to do some intel on that. Sorry, go ahead if you know.
No, so we can definitely see what's up with that, but of course you do have the alternative of the full face shield if the goggles aren't working for you, if you wear glasses or whatever. But we'll check that out. Appreciate the feedback.
Maybe baby shampoo? Not sure about that.
So the hospital protocol that came out yesterday, is that our protocol or the hospital? And I think Craig mentioned, but that's a joint protocol that both have agreed to. It was developed together jointly in discussion with all of our hospitals, and all of our hospital systems have supported it, just as we have. And I know that there'll be a few kinks as we knock out the bugs and getting it up and running, and certainly ask for your patience and understanding as we figure this out. But the fact that we're getting that stuff up and running and in place before we get really slammed is only to our benefit. So, yeah, I know it's new. I know it changes the way things happen. You may have some minor bumps with it, but it is endorsed and supported by all of our hospitals as well as EMS. So it's our joint plan with the hospitals. More fogging goggles. Okay.
Yeah. So purchasing your own goggles, I would say, is up to your agency. If they allow it, then certainly that's permissible.
Sure. There's another question here about any consideration to having EMS or fire employees wear N95s outside of work when in public to reduce the possibility of infection. I would say that's a personal choice for you, but we cannot support that PPE right now based on needing to keep it available for the work. Would you agree with that, Craig?
Yeah, we've got about 3 weeks of N95, and then we've got alternate PPE behind that. We're still we're getting some in, but we wouldn't be able to support it, 24/7.
Yeah, and that couple of weeks supply is based on current call volume, not what our call volume could look like in a week and a half from now. So we really are trying to find the absolute right balance between keeping you protected and maximizing our stock. So I think right now, I think there would be agreement that we can't support you guys taking PPE home to use there. Okay, so if we respond to an incident and we do not consider it related to COVID, treat and transport, what communication is there? I think it means if the hospital decides to test them. So that comes back via the normal mechanisms. And in fact, I just, while we were talking, got an email from Department of Health about that very thing. There is the designated infection control officer at each agency or hospital, and that person's job is to coordinate with DOH and coordinate with the other infection control officers and make sure that information flows back to anybody who was potentially exposed in the course of their work. So that process exists. It's always existed. It's the same thing we would do for a TB patient or any other kind of infectious patient, and we have seen that it is working. We've seen multiple rounds where the hospital decided to test somebody that we weren't considering suspicious, and that information does make it back to us. So that's the first half of the answer. The second half of the answer is because you're in an N95 and eye protection on every patient encounter, even if they turn out later to be positive, that keeps it a low risk exposure for you because at least you had eye protection and an N95 mask. And so that is often enough based upon the risk stratification to keep you from having to be out for 2 weeks in quarantine because we know that that's a fairly low risk exposure. And that really is the reason, that level of risk mitigation is the reason why we want you in the mask and the eye protection on every single patient for that exact reason. But that designated infection control officer process is working, and so you will get feedback back if somebody that you transported tested positive. All right, next one is the question of the day. The question of the day. So this is the one. Are we changing airway management protocols on cardiac arrest? For example, are we doing endotracheal intubation as opposed to King airway? And the answer is, wait for it.
Oh my God.
So the answer is, I don't think so, not yet, maybe later when we get to red. I thought I was going to be able to, in good conscience, say that based upon the risk-benefit stratification and the incremental survival benefit of a King airway over an endotracheal tube. I really thought I was going to tell you guys that, and I may have even mentioned it in passing in a previous discussion. but based upon some new information that's coming out just in the last 24 hours, I'm not sure that that risk benefit stays the same. And so that is an issue I am actively wrestling with to try and get us to the right answer in the next day or two. Um, I guess what I would say right now is if you were under the impression that that was what we were asking you to do and you tube somebody instead of putting a king, okay, well, I don't think anybody would give you a hard time over that. But for right now, there has been no official change in protocol related to airway management. So for right now, the answer is we do as we normally do. We take protective measures, which is making sure you're in that full PPE, because to be honest, the balance between what kind of aerosolization you get using a king tube versus what kind of aerosolization you get during the process of placing an endotracheal tube, I don't know the full answer to that. I know that both of them are extremely risky procedures, and I know that I want you in full PPE at this point anytime you're doing those procedures, and that I think is how we're going to keep you safe, at least in our current operations model, based on being in category yellow. But that could change with more data, and that could change if we move to red or God forbid, black. I know this has been a point of contention. A couple people have asked me about it. And what I would say is based upon the best information I have right now, I can't say that there's enough of a risk reduction moving to an endotracheal tube versus a king tube to justify that potential increased mortality to the patient. So I think right now we need to take full PPE on airway management and keep going according to our normal protocols. But I am really actively wrestling with that question, and I'll leave the caveat that my answer could change in the next 48 hours depending on the information coming out. And that's going to be a struggle as we go along with this. This is such a new thing. We don't know what drugs really work or don't work for it. You've heard a lot about, there's this question, should we intubate early and aggressively, or should we try to nurse them along on BiPAP for as long as we possibly can? These are active questions that nobody, frankly, has a really good answer to. And so the more, unfortunately, patients that we're seeing, the more information we're starting to get, and our answers to this stuff may change. But for right now, the bottom line answer is take appropriate protective precautions for yourself and follow our current protocols. Hopefully that answered the question. All right. Next one I think is going to be for you, Craig. I have seen and heard that there are special rescues in the system now responding to certain types of calls. Can you elaborate?
Certainly. So yesterday and today we fielded, yesterday was 2 and today might be 3 special rescue units. So it is St. Pete Special Rescue 1 and 2 and a Sunstar unit or 2. And they're going out as a 3-person crew, and they're responding to abdominal pain, breathing problems, chest pain, sick person, and unresponsive Alpha and Charlie with respiratory isolation precautions. And so we're continuing a regular system response at this time. But the idea being, as we ramp this up, this would be an overlay to the system to try to protect the workforce and to try to take some of the call volume down. As Doc was saying, our transport volume is down right now. And so we've got ambulances sitting with just a little bit lower workload. So we don't want to turn this on, but we did want to experiment with it. Yesterday seemed to go pretty well. Today, we'll get kind of a debrief on how it went. And the idea being that we would dress them out full face P100. When we get busy, they might go a couple calls back to back, and then we would decon them and send them to rehab directly thereafter. So the idea is trying to reduce our cycle time on these type of calls, and how sustainable can we make that. So see if anybody has other questions, but really at this point, it's just an experiment for a couple days.
And there's a follow-up question, Craig, which is, with the implementation of those units, is it acceptable to transfer care and not require the FD medic to ride in?
Yeah. So right now, we're on the agencies may opt to cancel either en route or on scene. And so I've not talked to each chief about that yet. So we're allowing that to just kind of percolate during the test phase. But Clearwater, Largo, Pinellas Park, Seminole, St. Petersburg, I need to talk to other chiefs in terms of either canceling on scene or canceling en route, which would be eliminating that ride in.
Great. Okay. Next one is from Jake. If I'm transporting an interfacility on a vent using an N95, do I have to throw away after every patient or continue to use? And it's the same answer as before. If you've actually been up close and personal with a patient, been treating that patient using the mask, we are not going to reuse those masks at this point. I mean,
I suppose that could change in the future, right?
It could. It
We'll
could.
talk about that a little. Yeah.
Yeah, it could change. So there's a lot of talk, and some of you may have heard this about using vaporized hydrogen peroxide or ultraviolet light or a couple other mechanisms to try and sanitize or disinfect or reuse an N95 mask. The one that looks the most promising is the vaporized hydrogen peroxide, and we are looking at that actively. And there was actually just a presentation on it from Duke University this afternoon that we had a couple people watching to bring us back the intel from. And if that becomes a viable strategy for us to extend the life of our N95 masks, then we will probably use it. But we don't quite know enough about it or have enough confidence in it right now to say that that's a good thing to do. You may start to see at your individual agencies, at least to begin with, a request to capture your used N95 masks in case we decide to be able to process them for reuse. But we have not turned that on at a system level yet. We're still investigating. That could change within a few days if we get more information. So right now, again, the guidance is if you make patient contact, you participate directly in patient care, you're up close and personal with a patient, then we are not going to reuse that mask. All right, the next one is a bit of reference on the condition colors. Would the condition of New York be considered red, or is that leaning towards the side of black? They are getting awfully close to black in New York right now, based on what I'm hearing. They've got 25+% of their workforce out. Their call volume is 150+% normal. There was one medic from New York who described going to so many cardiac arrests in one shift that their defibrillator batteries were dead. So the text messages that I was sharing with you from my colleague up in New York from last night, she was talking about the sheer volume of people they're pronouncing is overwhelming even to the online medical control system there. And so they're getting awfully close. Their resources are pretty close to tapped. She told me here, I'll just make sure I quote her correctly. She said, think about how to underutilize all resources. We changed BLS from 2 EMTs to an EMT and a CFR, and ALS is a paramedic and an EMT. Find a way to create more units. So they are really struggling. They are probably getting close to condition black, where they're just trying to do the best they can with what they have, but the normal standards of care are pretty far gone.
Yeah. I'll tag on to that one. So if you look at some of my earlier comments about our overall incident objectives of mixed crews and whatnot, that ultimately could be putting all the metal on the street with whatever staff you got. And so that would be up to 150 ambulances in this system, because figure as we're getting overwhelmed, you're not getting mutual aid from across the state or across the country. You know, we're going to have to run what we've got. So,
yep. Diving mask defogger may help, and I think I saw Chief Cepetto say he's purchasing divers defog for his guys. Good idea. So, since we are not using tablets, EPCRs during full ISO precautions in transport, can Sunstar place dry erase markers in all ambulances to be able to write patient information and intervention teams on the wall above the bench seat and to keep track of times and be able to document after the call is over. So this is a really amazing idea, and I believe it's being tested in the COVID units, is what
Yeah.
Mr. Champ told me. And I think this is just the coolest idea ever. Yes. So the answer is yes, that is being trialed right now to see if that would work well. Um, but particularly being trialed on those COVID units for now and could roll out further. Um,
So as we're building and trialing that is how do we make it quicker? And so we're talking about maybe we Visqueen. We're running Visqueen for the special rescues. Do we expand that to regular rescue and ambulance with the idea of we can spray it, let it dry, and be back in service more quickly than we know it's taken a lot of manual time um, to manually wipe down with peroxide wipes.
gotcha. Yep. Um, Okay, any new information on how this is affecting our younger population and specifically any information on immunocompromised youth? I don't have specific information on immunocompromised youth. I would say that the distribution of cases, who's being really affected, um, the age range of people with severe disease extends lower than we thought. I did speak to somebody in one of our hospitals here locally the other day who said they had a 28-year-old on a ventilator. And I said, sick? Like underlying stuff? And they said, not so much. So I think the initial messaging that this is really a problem for older people and immunocompromised people may not be entirely true, but a lot remains to be seen as to how this is going to look. I guess what I would say is that messaging you saw from the feds a couple of weeks ago about, hey, millennials, this is important for you too. That was said for a reason, and it was said because the age distribution of people getting severe disease from this virus is lower than we initially thought. Necessarily high risk, but that does not mean that there will not be kids and young people who get sick. There will be some. I don't know how many yet, but there are certainly some already, and there will be more. This one, how are we allowed to use our clinical judgment to de-escalate calls away from full PPE in the event of no flu-like symptoms and no aerosol generating procedures? Excuse me, I'm gonna cough now. Sorry, talking too much. I promise I don't have it. Are we allowed to de-escalate away from full PPE? Yeah, look, nobody else can be responsible for your safety but you. We're doing our very best to give you as much information as we can, whether it's dispatch pre-arrival notes, whether it's what questions to ask the patient when you get there, what symptoms to be looking for. But nobody is at the end of the day going to be able to protect you except you. If you get to your patient and you are confident that they are not a COVID patient and you are confident that they are not a cardiac arrest, I hope you're confident about that. And if you're confident that that you're not going to do any aerosol generating or airway procedures, then I think it would be acceptable to proceed with just a mask and eye protection. But only you can really make that decision in front of the patient. And Craig, I'll let you chime in a little bit on that because I got to answer this consult.
Sure. Yeah. So patients lie, just like House, the guy on TV, talks about. We've had two crews have exposures based upon the patient lying to them, and so I wouldn't be too complacent in that. I think that the minimum PPE of goggles or face shield, N95, and gloves, I wouldn't want it back below that because as soon as you think that you're safe on that, and then we have an exposure, notification. You're going to be out of play for 14 days. That doesn't help us or you or your family. So, also with asymptomatic spread, I'm thinking that that's you can't really always assess that.
Yeah, agreed. Sorry, I'm back. I think we had one of the other docs was watching and saw it come in and jumped into cover. So thank you.
Oh, nice.
Thank you, MD2. That was very nice of you.
Very good.
So, yeah, I think what you mentioned there, Craig, was dead on. The reason for, again, the reason for the minimum face mask and eye protection on every single patient is that it's tough to know. Some people have described the COVID virus as a very, very cryptic virus that presents in lots of different ways. It can attack the lungs, it can attack an upper respiratory type thing, it can attack the GI, and it can attack the heart and the cardiovascular system, among others. And that's what we know about so far. So, you know, it, it's tough to say, well, I'm sure it's not. That's really tough to say. Okay, next is anything other than anecdotal data on a Plaquenil efficacy. So Plaquenil is the hydroxychloroquine. It's an old malaria drug that people have been talking about a lot. And so there was some initial data out of China. And then now what I can tell you is they are currently enrolling over 1,000 people in a randomized controlled trial up in New York City. And I hope that they will have some data out on that as soon as possible. I was hoping to see something else come out in this week or last week. I haven't seen it drop yet, but I hope we'll get more data on that shortly. I would say, Chief, that in a time like this, our standard of randomized controlled trial is not feasible, and so we have to rely on case series reports and expert opinion, unfortunately, and that makes things a little tougher to say definitively. So no, I don't have any definitive evidence-based proof that it's working yet. There's stuff starting to trickle out, and I think we'll know more soon. Kenny says, have we looked at ketamine or rock for intubation protocol to paralyze and prevent the patient from respirating and generating droplets, increasing risk to clinician? So no. The ketamine and rock would be, or really a paralytic, would be good for facilitating the intubation procedure and for getting compliance with a ventilator or your BVM, if that's what you're doing. But there's a lot of discussion right now that I actually heard somebody say, for those of you who know the MCRIT podcast, Scott Weingart actually said last night that he's having to change his love for rock and consider using sucks in these patients so that they start having some respiratory effort on their own as soon as possible, because paralyzing them and intubating them seems to de-recruit alveoli, increase VQ mismatch and shunt, and cause them to clinically deteriorate. And so that's where this discussion about maybe we shouldn't be early and aggressively intubating and paralyzing all these people is starting to come from. That's why people are starting to talk about, well, maybe CPAP is really a much more important treatment methodology here. Now, that makes it difficult for us because CPAP is certainly more dangerous than having a tube in somebody. But the procedure of intubation is probably just as dangerous as putting somebody on CPAP. And as far as the prevention of the patient having respiratory effort and generating droplets while they're intubated, while the rock would stop them from having their own respiratory drive, there's still going to be air going in and out that can cause droplets. And the key there is actually the filter on the vent circuit or the filter on the exhalation port of your BVM, which has a HEPA or viral rated filter on there. So that actually gets you pretty good protection. Now, I don't want you to rely on that because obviously we've all seen the bag pop off of the tube. But that once you have that closed circuit of a definitive airway with a balloon up and the exhalation filter, you're actually pretty well protected. Again, we can't rely on that, but it does significantly cut down the number of particles that are coming up into the air. All right, Becky says, are Sunstar EMTs participating in cardiac arrest that require full PPE? So I'll take a stab at this and I'll ask Craig to talk from an operations standpoint about this as well. Basically, because we know that there's some percentage of patients that we won't know that they're a COVID patient that may or may not be cardiac arrests, and because we know that cardiac arrests are aerosol generating procedures and therefore inherently higher risk for us, the idea is to minimize the exposure, just like on any other call um, where we're doing these types of procedures. So based upon the current model, I think that if you have enough other personnel, the Sunstar EMT probably should not participate and maintain a standoff so that they can be the vehicle operator and not have to use multiple sets of PPE during the call. That was sort of the whole reason for that initial decision. And maybe, Craig, maybe you want to talk through how that operational scheme came to be in terms of who does what with the fire ride and stuff.
Sure. So the basic scheme here is we don't have a good way to decon the cab of the units, whether a rescue or an ambulance. So that got us into how do we keep a clean cab? And that was keeping the vehicle operator, EMT or medic, assigned to the unit. And then in terms of PPE conservation, only having one medic from fire and one medic from the ambulance, and that way the minimum that you can use to safely move a patient on a cot is two personnel. And so, trying to align that, you know, not really the best thing, in terms of having to do ride-ins or, keeping the call flowing like that. But it has been pretty operationally efficient from what we've seen so far.
Great. And Kenny, I see you say maybe one day, Doc. One day I can only hope, and I agree with you. I hope we get to RSI in this system one day. We have a few steps we have to put in place before we can get there, I think.
I heard intubation frontline is coming back, so maybe.
Um, that honestly, that could be the case if we get to direct unprotected exposure to a positive CV patient but not tested. No longer a risk of infections to other. Asking for a friend, of course, of course. So look, there is guidance about this. You can refer to the CDC website, and your administration has these links. We'll be putting them out again as part of the package this week. But the general the general guidance right now is that if you've actually been symptomatic and we think you have COVID, then you need 2 sets of negative tests spaced by at least 24 hours before you're considered safe to come out of isolation. And that's a pretty tough hurdle to get above, particularly since viral shedding has been shown to be somewhat intermittent in the aftermath of this. So that's a situation you probably need to talk through with your agency infection control officer. And we've made sure they all have the resources for the CDC guidance, but you can see it yourself. If you just go on the CDC website for information for healthcare providers and click on the occupational exposure stuff, it will walk you through exactly what the risk stratification is and what the procedures are supposed to be. All right. So I'm getting a text message question. Oh, this is awesome. This is amazing ingenuity. I'm going to hold this up to the camera. We'll see if it actually, let me see if it, yeah. See if you guys can see this.
Oh, wow.
Well, if Craig would stop talking, it would show my screen. Okay, so this is an idea that somebody's putting on Facebook or something like that of using a BVM mask. So there would be a face mask to shield from any spray coming up from the mouth after you are intubated or have a king tube. I love it. It's amazing. Good ingenuity. I haven't seen that before. I could take a look at it, but there's lots of interesting things people are trying with filters and masks and all sorts of stuff. I think what I would say is for the moment, if you have a airway in and you have a balloon inflated with a pretty good seal and you have a exhalation port on, so I think somebody in the comments is taking credit for that picture. That's great. So if you have a filter on your BVM exhalation port and you have a seal a good seal with a balloon up, there shouldn't be too much more coming up, most likely. So that is probably the best we have right now. There are people who are talking about putting like clear plastic sheeting over, like surgical drapes, that kind of stuff. There's some company that's making what they call it, an aerosolization box that like fits over the whole patient's head. It's like has armholes like a chemistry hood. So there's all sorts of stuff that people are doing. But no, I don't think I can endorse. Okay, now he's retracting his credit for the picture. Okay, very good. Um, uh, Jacob says it looks like an old EOA. Maybe. I guess necessity is the mother of invention, huh? Okay, so what is okay? So there was another one here. Is there a study on damage lasting effects to survivors? No, because we don't have enough survivors that have been alive that long to know what those effects or damage are. But I'm sure that will happen. I think anecdotally, I'm hearing that if you're on a vent for a week or two, you're going to have some lung and trachea damage. That's sort of a given, just from the pressure of the ventilator on your lungs. So it would not surprise me that if you've spent some time on a ventilator, you're going to have significant potential lung dysfunction as a long-term effect. All right, I'm getting a text message that I have a question in my email, so let me pull it up here. Okay, 2 questions. Come on. Let's see. I hear that the government is making funding available for paramedics to do telemedicine, video chat with a patient via their smartphone. Can we foresee setting up a team to do telemedicine with COVID patients? Yeah, we've thought about that. We've thought about any number of ways to do that, and we don't have a good solution yet. So it's not officially part of the plan, but it's certainly something that is being looked at. And the follow-up question was, can you foresee some form of triage and dispatch to direct COVID patients to telemedicine versus actual response? Yes, that is tentatively in for a certain subset of 911 callers once we get to category red or black. I can't remember exactly where it is, but yeah, that is in the mix as well. And then the person put a link about reimbursement for it, which I don't care about. That's Craig's side of the house.
Hey, we care about that. So, Jonathan Washko was on that email. He's the chief for Hopewell Health on Long Island, a good friend, and they're getting overrun up there. He's shared a lot of information, and so we've passed along the Medicare guidance to our billing and finance folks, and I can see more and more telehealth. Look at how the world has changed so fast here.
Yeah, for sure. There's a lot of moving parts on this one that may push us to that, and it's remains to be seen, but likely part of it. I think I might have one other one here on my phone. Oh, I think this is the same question that we had before about downgrading PPE. Okay. What else haven't we answered? Has there been any reliable info in regards to immunity after recovery? Yeah. This is a bit of a troubling one still. One of the reasons why this is such a nasty little bug. So it would appear that you likely have some resistance to reinfection for at least a couple of months after infection, but that is preliminary data. The long-term resistance or immunity remains to be seen. And there have been significant reports of people with recurrent or reactivation type disease where you're sick for a week or 2 sometimes is what's happening. Then you get better for a week or 2, and then you get sick again. And it's unclear whether that's a reinfection or a reactivation. And so the answer is no. There's no reliable info yet. And the way that that the immune system interacts with this virus, where you don't have that standard immunity to, like, you got the flu once and you're done, is one of the things that makes creating a vaccine for it potentially somewhat troublesome. And so it's also one reason why the idea that we're going to have a quick vaccine is probably unrealistic. Next is, are they using pressure control setting or vent controls or volume control settings on the vents? Good question, Jacob. I would point you towards the MCRIT site and the MRAP site, and I think the Life in the Fast Lane site. All of them have extensive discussions of the respiratory physiology of these patients. And we don't really know. And I would say that a day ago, I would have given you a different answer than I'm giving you today. The best answer I've heard today is that if they can do it, intubate them and put them on BiPAP settings, which is a weird thing to consider, but based on what I'm hearing now, might be the right thing to do. So I don't quite know yet, and I think that that's changing rapidly in terms of our understanding. There's a little discussion starting that the lungs in these patients look more like high altitude pulmonary edema than anything else, and the physiology behind that is totally not understood yet. So it's troublesome right now. All the guidelines from a week ago are sort of upended this week. So see what you find on those sites, Jacob, but I think it's very much in flux. Okay, here's another one. With the impending upswing in the number of intubations, any thoughts about providing some sort of video laryngoscope to aid? But I don't think I'll get away with that. No, there is no current plan right now to spend that kind of money at present time. It sure would be nice, and I you guys are all alluding to it. You know my stance on this. If I could get us to RSI with video laryngoscopy and appropriate levels of time for training and practice, I would certainly be doing it or be pushing for it. But those are some hurdles that we have to overcome, and I'm not sure that now would be the appropriate time to try and get that done. Here's another one coming in. So somebody's telling me that I did not answer the question about downgrading PPE. I think I did. So the answer is, if you get there and you decide that you definitely don't think it's a COVID patient, you definitely don't think you're doing airway management, you definitely don't think it's going to be a cardiac arrest, and you're definitely not doing any aerosol generating procedures, then it's on you if you choose to downgrade. However, downgrade cannot be past N95 and eye protection, which is our minimum standard on all patients right now. Hopefully that covers it. Doc, I saw a... yes, Kenny, someday. I saw a bunch of disposable pens for the tablets trickle into our EMS stockroom. Is this the plan for COVID refusals? So we have had a lot of recent discussion about COVID refusals and how to do that, and maybe I'll kick that one to Craig for the legal and operational aspects on that one.
Sure. So we're working on that currently. I've got a request into county attorney for a legal review of that. And so just kind of stand by for that one. Kind of both pieces is us on a stay at home and our regular refusals to make sure we're not having to decon the tablets every minute.
Yeah. And as we get further into this, there may be a assessment and triage to non-transport protocol that comes into play. And so capturing consent from the patient at that point would also be something that we have to figure out. Next is, if we have to decon the whole unit after a possible COVID call, even surfaces that the patient isn't in contact with, how isn't the medics clinician exposed if the gowns aren't completely covering them? So it's not that we don't want you to wear a gown on the COVID call. We absolutely want you to wear a gown if you have any indication that it's a COVID patient, and that would be the same time you would decon the unit. What we're asking is that even if you don't think it's a COVID patient, we want you in an N95 mask and eye protection on every single patient. So in that case, we wouldn't necessarily need to do the full decon of the ambulance, but we at least have some baseline protection for you on the off chance that that person is actually infected and we just don't know it. And so that PPE is about protecting you. Decon in the ambulance is really about protecting the next patient.
We'll talk through then, Doc, the deconning the ambulance. So there's a low risk and there's a high risk in that. We've got some new decon guidance coming out here shortly.
Yeah, I don't want to get ahead of the guidance, but basically, the amount of decon has to do with whether or not you know or really suspect it's a COVID patient and what you did with that patient in there. So if you were in full PPE to do airway management or cardiac arrest or a neb or something like that, then maybe it makes sense to decon. But if you just have the N95 and the eye protection on for the sake of protecting yourself on the off chance that this is an asymptomatic carrier, then that's not somebody that we can necessarily take a half hour to do a full decon of the ambulance on. Next one is piggybacking off the other question. Is it acceptable to take verbal refusers and have clinicians sign to keep the number of people touching the tablet to a minimum? Well, I think we covered that, or maybe we didn't. I don't know. Do you think we covered that sufficiently, Craig?
Well, not yet. So we do have kind of a general thing where, because of contamination, to not take a signature. But we want to clarify all that before we kind of have a massive change in the number of refusal signatures. So try to keep them going in the interim.
Yep. Yeah, it's definitely an issue, and we're trying to figure out the best solution for you, but we don't have the answer quite yet. Okay, looks like we're coming up on almost an hour and a half, and the question seems to be trailing off. So I will say this is your last opportunity for today to throw up any more questions that you have. We'll give you a minute or two here to throw the last ones up. We will be planning to come back to you on Thursday, and I'm very hopeful that by then we'll have much more of the playbook all ready for you, including the clinical standards and clinical alterations, as well as updated on PPE, on decon, on post-exposure, all those types of things, so that we can sort of have our framework for how we're going to weather this storm pretty well nailed down. There's been just an amazing amount of work going on with people getting ready. And I think that as we get to the end of this week, we will be about as ready as we could be for what's coming at us, because we don't know how steep the curve is going to be, and we don't know how high the wave is going to be. But I think that everybody has been working all sorts of hard to get us ready and to keep you guys safe. And I certainly appreciate what it takes to go out there and be interacting with people in an environment where everybody else is staying home and practicing social distancing. I get it. It is not easy to show up and get on the truck and start answering those calls with all the uncertainty, all the lack of information, and all the anxiety that's out there. So I certainly appreciate that. I appreciate what you guys are doing for the community. I have those same feelings when I go to the hospital. So, hang in there. I know this is tough, and I'm afraid it's going to be tougher before it gets better. So I do appreciate everything. Stay safe and take care of yourselves. And I think with that, we will go ahead and sign off.
Stay safe, everybody.